Good morning, everyone. Please verify that you can hear me. Okay, thank you. So I'm not sure the number today is only 3 or 4 people, but we will have to start anyway. Today we will be talking about one of the important topics in the exam, in practice, and it's diabetes. So if we come to remember first some basics about diabetes, we have 2 main types. The first one is type 1 diabetes, and what happens in type 1 is a complete lack of insulin due to beta cell destruction in the pancreas. And this is not the common type. The common one is a type 2 diabetes, which happens either due to less sensitivity of cells to insulin or less production of insulin by pancreas. There are other minor types like gestational diabetes, which happens during pregnancy. And how to treat each one of these is different depending on many criteria that we will discuss here. Okay. So when will we decide that someone has diabetes? So first, if the HbA1c, which is like the glycosylated hemoglobin for the last 3 months is 6.5 or more, or if the fasting blood glucose is 7 millimole per liter or more, or if the random blood glucose is 11.1 millimole per liter or more, and the random blood glucose is the one after the oral glucose tolerance test, which is like we ask someone to take some drink with sugar, and then we measure the blood glucose in blood. And based on that, we measure the blood sugar, and we find that it's 11.1 or more. Okay. What are the clinical presentations? What are the symptoms of diabetes? So if we go from up to down, like from the brain, you will find that the patient feel a kind of polydipsia, polyphagia, thirsty and hungry. The patient is lethargic, like feeling fatigue. If we go down, you will find that the smelling of the breath is like ketone. And also the patient might start to encounter some weight loss, some nausea and vomiting. And also the patient has polyuria, which is like going to the washroom for urination more frequently. What are the risk factors for diabetes? Older age, if the age is 40 or more. If the patient has a first-degree relative with type 2 diabetes, this increases the chance of developing diabetes. If the patient is pre-diabetic, and when we say pre-diabetic, it means that the HbA1c is between 6 to 6.4, or if a woman developed gestational diabetes during pregnancy, it has a high chance of developing diabetes type 2 after giving birth, delivery of a macrosomic infant, or if someone has end organ damage like kidney dysfunction, this leads to less ability of the body or the kidney to get rid of glucose, and this increases the chance of developing diabetes. Okay. There are also other vascular risk factors, like if someone is obese, if the HDL is less than 1 millimole per liter in males or less than 1.3 millimole per liter in females. We don't need these details, just we need to go through it, but you don't have to memorize it. And it can be deduced logically. If the patient is hypertensive or overweight, if the patient has a high triglyceride, 1.7 millimole per liter or more, or if the patient is a smoker. Okay, so when to do screening for diabetes? If the risk factor is high, like the patient has any of the risk factors mentioned before, we need to screen every 6 to 12 months. But if it's a low chance, like for example, if a healthy person with no family history of diabetes, but his age is 40 or more, we can do the screening every 3 years. For other people, no need to make screening, like normal healthy people less than 40 years. Okay. Then what are the HbA1c targets? Generally, it has to be 7 or less. This is on a general rule. However, if the patient has nephropathy or retinopathy, it means that we need to take the glucose level to a less level to decrease the chances of the progress of nephropathy and retinopathy. So we can reach with HbA1c until 6.5, but the patient has to show no chances of developing hypoglycemia, because if the patient is at risk of hypoglycemia and I try to take his HbA1c down to 6.5 by trying to decrease the level of blood glucose in his body, this might lead to hypoglycemic coma. So the patient has to be at no risk of hypoglycemia. In certain population of people, I might accept HbA1c of 8.5 or less, and this happens in the very old people who has a low life expectancy, or if they have end-stage disease. At that point, I can be more flexible with HbA1c up to 8.5. Okay. There is something we call ABCDE triple S of cardiovascular disease with diabetes. Like if a patient has diabetes and at the same time has any cardiovascular disease, what I need to keep an eye on? I keep an eye on the HbA1c to keep it under control. The blood pressure has to be less than 130/80. The LDL should be less than 2 millimole per liter, or I should achieve 50% reduction of baseline LDL or more. I have to add some medications to achieve protection, like statin, ACE inhibitor, and maybe aspirin. We will see that later. Exercise has to be at least 150 minutes per week of intense aerobic exercise. If the patient is a smoker, we need to encourage patient to stop smoking. We need to achieve stress management, and we need to make regular screening. Okay. A patient with diabetes, I have to monitor the negative consequences of diabetes, like retinopathy, nephropathy, neuropathy. I need to keep lipid profile and the blood pressure under control. So regarding retinopathy, we don't have to know that we use the fundoscopy or wide angle stereoscopic retinal photography. We don't need to do that. All what we need is that we need to make retinal eye exam more frequently. First at the time of diagnosis, and we can repeat it every 1 to 2 years. Regarding nephropathy, I need to make the kidney function on a regular basis. Don't confuse yourself with the numbers. Neuropathy, also the doctor neurologist has to make some tests on a regular basis every year to make sure that the nerves are still functioning appropriately. For the lipid profile, we need to do that annually. And if we already started treatment for diabetes, because we don't have to start treatment in each diabetic patient, but if we started to give treatment already, we need to make the lipid profile screening every 3 to 6 months. Blood pressure has to be on every visit, and the patient has to have like a machine at home. And the food examination, it's done annually by the doctor, but we need to ask the patient to check their food every day. Because if there is a small injury in the foot and the patient is diabetic and there was like any small injury, it might lead to severe consequences, might reach to amputation. This is why we need to ask the patient to do foot examination by himself or herself on a daily basis. Okay. Any question until now? Okay. So, when to start therapy? If the increase in HbA1c is less than 1.5 from target, no need to start like medication therapy for 3 months. Like let's say, for example, the patient HbA1c is 7.5. I don't need to start therapy right away. I can ask the patient to start the non-pharmacological measurements like exercise, like some amendment to diet. And after 3 months, I will reassess the patient. If the patient is showing clear improvement, I can ask him or her to keep on doing that until we reach to the target of HbA1c. But if after 3 months, I see that there is no clear improvement, at that point, I will start metformin. Okay, if I measure the HbA1c, and it's higher than 1.5% from target, at that point, I have to start metformin. If the patient is showing like severe symptoms of hyperglycemia or metabolic decompensation, like diabetic ketoacidosis, and we will talk about that later, I need to give the patient insulin at that point, in addition to the regular oral tablet like metformin. Okay, so generally speaking, before talking about this slide, metformin is the first line therapy of diabetes because it has a direct impact on reducing the blood glucose level in blood. Additionally, it has cardiovascular benefits, it decreases mortality. This is why it is the first line. If metformin alone is not enough, we will have to add something in addition to metformin, depending on some givens, like the weight of the patient. If the patient weight is high, I will avoid something that might increase weight, like sulfonylureas. I will give something to help in controlling weight. If the patient has a risk of hypoglycemia, I also might avoid sulfonylureas. I will go to something else that doesn't cause hypoglycemia. If the patient has a cardiovascular disease, I will add something with cardiovascular benefit, something like liraglutide, which is a Saxenda injection. We will talk about that. Something like empagliflozin. Both of these medication, liraglutide, empagliflozin, show a good cardiovascular benefit. This is why we might add it to metformin if the patient has any cardiovascular issue. Also, if the patient has a kidney disease and I need to give him sulfonylurea, for example, I will avoid the glypuride because it's contraindicated with kidney dysfunction. and I will give something else like gliclazide. Okay. Okay, before we start talking about medication, any questions so far? Okay, it's Ayman who only respond to me, but that's fine. Okay, so we will start by talking about metformin, which belong to the family of biguanides. And this is the only member of this family used anyway. So the mechanism of action of metformin is by decreasing hepatic glucose production, and also it increases the insulin sensitivity in cells, so it decreases the glucose by enhancing the uptake of insulin by cells. It's a first choice, as we discussed. It's not associated with weight gain, and this is a good point to consider. It helps in reducing the HbA1c by 1 to 1.5%, which is a great number for an oral medication. And also, we said that it reduces the cardiovascular risk, it decreases the mortality, and this is a good point about metformin. However, it still has side effects. So it potentiates the hypoglycemic effect of insulin and sulfonylurea. Like, we know that the most common side effect associated with insulin and sulfonylureas is hypoglycemia. So metformin, if taken with any of these, will potentiate this hypoglycemic effect. Metformin might cause lactic acidosis. And this is one of the things that might force the physician to stop metformin and give the patient something else. Okay, other side effects that are not mentioned here, metallic taste, and also anorexia. The patient has less desire to eat. These are so common with metformin. One of the most side effects associated with metformin is the stomach upset. And this is why we ask the patient to take metformin after food to limit the GI upset. And also you will find that usually if a patient is starting metformin for the first time, the doctor will ask him to take like low dose, like half tablet or the 500 milligram twice daily after food for 1 week. Then the patient can go up. And the reason for that is that to limit the GI effect, we are giving a chance to the body to familiarize with metformin, then we can use a higher dose, but it has to be after food at any time. Okay, so contraindicated if creatinine clearance is, this is not accurate. Okay, so metformin is contraindicated if creatinine clearance is less than 30 ml per minute, contraindicated. But we decrease the dose of the creatinine clearance is less than 60 ml per minute. Again, here, metformin is contraindicated if creatinine clearance is less than 30 ml per minute, but if creatinine clearance is less than 60 ml per minute, we will need to decrease dose. So we need to correct that, okay? If a patient is acutely ill and unable to maintain fluid intake, we have to stop metformin at that point. And this is something called sick day management, and we will talk about that later. If the patient is going to have any imaging contrast agents, we need to stop metformin 48 hours before the contrast dye, like someone, for example, has acute kidney injury and is going to get imaging contrast, we need to stop metformin for at least 48 hours. Other things we need to know about Yeah. So I mean, I was saying that this sentence is not accurate for creatinine clearance. If the creatinine clearance is less than 30 ml per minute, metformin is contraindicated. Okay. But if creatinine clearance is less than 60 ml per minute, we just need to decrease the dose. Okay. My pleasure. So metformin decreases the absorption of vitamin B12. This is why it's recommended that we advise the diabetic patient who is on metformin to take supplemental vitamin B12. Also, metformin has to be, or some conditions has to be monitored for a patient who is on metformin, like heart failure or liver disease. If the patient has diabetes and heart failure and receiving metformin, the chances of lactic acidosis is higher. And the same if the patient has kidney dysfunction or hepatic disease. With these conditions, the chances of lactic acidosis are higher, and I have to monitor more frequently while being on metformin. Okay, the second family is sulfonylureas. And it briefly, like sulfonylureas, as we all know, it stimulates insulin secretion by pancreatic cells. I think someone is here. It stimulates insulin secretion by pancreatic cells, and this is how it helps in treating diabetes. This is why, for example, I cannot use it in type 1 diabetes, because in type 1, there is a complete destruction of pancreatic cells. So there is no point of taking sulfonylureas in type 1 diabetes. So sulfonylureas were found to decrease the HbA1c by 1 to 1.5%, which is a good number as metformin. But if we come to differentiate between two popular members of the sulfonylurea, which is gliclazide and glypuride, we will find that gliclazide is preferred in chronic kidney disease. However, glypuride is contraindicated in chronic kidney disease. This is something important to remember. Also, gliclazide can be used with elderly, and glypuride are not preferred in elderly because most elderly show decreased kidney dysfunction. This is why it's not recommended to use glypuride. Okay. The good thing about glypuride, which is weird, is that glypuride can be used in pregnancy. Okay, Ayman. So what I say is just that gliclazide can be used in chronic kidney disease, but glypuride is contraindicated in chronic kidney disease. So if you have a patient who has like low creatinine clearance or stage 4 or 5 chronic kidney disease and is taking glypuride, I need to make sure that he is converted to gliclazide or something safer than glypuride. Okay. This is about this. Something we will mention later is that in pregnancy, glypuride and metformin are the oral agents that can be used in pregnancy in addition to metformin, glypuride and metformin. Okay, the second one is acarbose, which acts by inhibiting alpha-glucosidase enzyme. Alpha-glucosidase is an enzyme that works in our small intestine, and it breaks down the complex carbohydrates, di or polycarbohydrates to mono sugars. So by inhibiting this enzyme, we don't have simple glucose to be absorbed. This is how it works. However, this medication is less effective compared to other medications for diabetes, and this is why it's not commonly used now unless in a specific condition. Okay. Now we are talking about a medication that inhibits a specific enzyme associated with food. So if I'm going to take the meal, I will take a carpose with the first bite of the meal because I need it to act right away on the enzyme. So the amount of sugar taken from the meal will be less. So it's taken 3 times daily. We eat 3 times daily, most of us, I will say. So if I skip a meal, no need to take a carpose because there is no point of taking it. Also, the impact of a carpose on HbA1c is less. If we remember about sulfonylureas and metformin, we will find that they were helping in decreasing HbA1c up to 1.5%, which is great. But for a carpose, it's 1% or even less. So its effect and positive impact on HbA1c is less. Okay, the problem with a carpose, because it acts on the small intestine on a specific enzymes, we will find that it's mostly associated with many GI side effects like diarrhea, abdominal pain. And this is why a carpose is contraindicated with people who has IBD, someone who has ulceration, for example, in the intestine, because it has a lot of GI side effects. So it's illogic to give something like a carpose in that case. Okay, the other point is, if you have a patient who is taking, let me ask someone here. Dina, can you open your mic, please? Ayman, can you open your mic, please? People, are you still alive there, or I'm talking to myself? Okay, it seems that I'm talking to myself. Okay, the questions that I wanted to ask is, if a patient is taking a carpose and the patient went through hypoglycemia and I need to give him some sugar just to increase, I can take Mr. Habash. Dr. Habash, can you open the mic, please? I miss your voice. Dr. Mohammed Habash, are you there?
Yes, how are you, Dr. Ayman?
How are you, sir? I miss your voice.
I miss you too. How are you?
I'm good, thank you. So my question was, if a patient is taking a carpose and the patient went through hypoglycemia and I want to give him some sugar, which one would I give him? Can I give him sucrose, for example?
Do you ask me or what?
Yeah, I'm sharing thoughts.
Okay. Just think this one will not make the polysaccharides digested. So if you give a patient with a carpose like starch or like disaccharides, sure it will not be absorbed.
Yeah. So I need.
And also, what I need to focus on here, this patient has hypoglycemia. So this patient has low blood glucose in his blood. So yes, it's better to give him glucose directly. No need to give him like a medication, then this medication or like sugar, and so sugar will be converted to glucose. Sometimes it is an emergency case. So give him glucose.
Right away.
Yes, exactly. In all cases, it's better to give him glucose.
Yeah.
Yes. Yes, if you don't have glucose and this patient don't take a carboz, you can give him like other one like sucrose or something like this. It's okay, it can be accepted, but not in this case, at least with a carboz. But also, if you have glucose in your hand, give it to the patient directly. This is the best thing to recover this patient because he has deficiency or low blood glucose.
Yes.
Yes, okay.
It's my honor, sir, to hear your voice today.
Thank you so much.
So the next family is thiazolidinedione, which we can name them glitazone. This family acts on a specific receptor, which is PPAR gamma, peroxisome proliferator activated receptor gamma, which is found on the cell nucleus. By acting on this receptor, the glitazone will increase the sensitivity of cells to insulin, so it will enhance the uptake of insulin by cells. The impact of this family on HbA1c is high, like metformin and sulfonylureas, up to 1.5%, which is good. However, this family is associated with many side effects that we have to keep an eye on. Okay, the first side effect associated with glitazone is that it might cause weight gain because it increases the subcutaneous fat deposition and it also causes fluid retention. So these two reasons contribute to the excess weight in patients receiving glitazone. Also, taking glitazone on the long run might lead to higher risk of fracture, especially in older people. Okay, what else associated? This family, glitazone, is associated with more respiratory tract infection. And also, it might increase macular degeneration. This is why the older people who have an issue with eye, the doctor will avoid glitazone and give them something else. Okay. One of the good points about glitazone of the ladies who were anovulous, who were not able to give ovules on a regular basis, have shown to have ovulation after receiving glitazones. Okay, can I use, let me take someone else. Sarah K, are you okay to open the mic?
Yes, I'm here.
Hi, so based on what we said about glitazone, do you think that we can use it in heart failure?
No, because it has a known, it is known to increase cardiovascular disease events.
Yeah.
It may precipitate heart failure.
Yeah, so we can say that the simple reason for not using glitazone in heart failure is that it increases the fluid retention and the edema, and the heart failure patient is already congested with fluids. So I will not give him something that increases the fluid retention. He is already congested with fluids. This is how we can easily remember it. Okay?
Okay.
Thanks, ma'am. The next family, which is like not important. Yeah, yes, Dr. Habash. They also, glitazone itself is one of the risk factors for developing heart failure. Repaglinide, meglitinide family acts by the same way like sulfonylurea by stimulating the secretion of insulin from pancreas, but the effect of meglitinide is lower than that of sulfonylurea, and it's shorter. So it's lower and shorter. Meglitinide, we take it with food, the same like a carboz. So we take it to control the direct postprandial glucose. Like I eat some food containing some carbohydrates, so my glucose level will go high. So I can take the meglitinide just before the meal or with the first bite of the meal, so I control the postprandial glucose. So if I skip a meal, skip the dose. If I skip the meal, skip the dose. The good point about meglitinide is that they are safe in chronic kidney disease, in contrast to glypuride from the sulfonylurea family. There is something I forgot to mention here about the glitazone, that now rosiglitazone has been discontinued in some countries, and in Canada, to give a patient rosiglitazone, because it's highly associated with many cardiovascular issues, the patient has to sign a consent that he or she understands the negative consequences on rosiglitazone on cardiovascular disease, on heart, and they will monitor the things more frequently. Okay, this is for rosiglitazone. Pioglitazone has also been discontinued in many countries. Okay, the next family, and it's a newer family compared to sulfonylureas and other glitazones, is the dipeptidyl peptidase 4 inhibitor. Okay, what is dipeptidyl peptidase enzyme? So it's an enzyme that breaks down the glucagon-like peptide 1, GLP-1, which is like a peptide that has a role increasing the incretin levels in our body, which stimulates the insulin secretion. So the enzyme breaks down the glucagon-like peptide 1, GLP-1, leading to less incretin, leading to less insulin in our body. So if I can stop this enzyme, dipeptidyl peptidase, if I can inhibit its action, it will end up by more insulin available in our body. It's called the gliptins family, allogliptin, linagliptin, saxagliptin, sitagliptin. And this family impact on HbA1c is not high like sulfonylureas and the glitazone. It decreases the HbA1c by 1% or less. However, it has some good points compared to other family. First, the bad thing is heart failure is one of the contraindications of using this family, especially the saxagliptin. If a patient has heart failure or coronary vascular disease, we need to avoid the use of saxagliptin. Also, the gliptin family is associated with pancreatitis and also nasopharyngitis. So if a patient is taking sitagliptin, for example, and come to you complaining of nausea, severe abdominal pain, you need to think about pancreatitis as the first possibility, and you need to transfer him or her to the hospital right away to be assessed. Okay. Generally speaking, they are taken as an added therapy, not alone. Like you will find that the patient is taking metformin, for example, and sitagliptin. At that point, sitagliptin will be once daily. Sitagliptin will be taken once daily if taken as an added therapy to metformin. If the patient is receiving only sitagliptin, it will be taken twice, not only once. We avoid it in heart failure, Ayman. Okay? May we leave the comments like just so I can focus? If something, we can share it like after finishing specific parts so we don't go confused. Okay. What else about the gliptin family is that in the beginning, if you find someone who started sitagliptin or linagliptin, you will find that the patient will complain about headache. This is so common with the gliptin family at the beginning, but after that, the body familiarizes with the medication and it goes away. So if the patient called you, for example, at the pharmacy during the first 2 weeks saying, I started sitagliptin and I have some headache, just ask them to take Tylenol and tell them that this is a common side effect at the beginning and it will go away after some time. Okay. Also, the gliptin family in rare cases showed some kind of Stephen-Jensen syndrome, the rash, like the severe rash on the body. If it happens, the patient has to go to the hospital right away and has to stop the gliptin, but this is rare to happen. However, it might happen. So just to keep an eye on that. The family F after that is the sodium glucose cotransporter 2 inhibitor. And the member of this family are the gliflozins, like canagliflozin, empagliflozin, dapagliflozin. The common one is EMPA and the cana. These are the 2 common ones. And this medication prevents the glucose reabsorption in the kidney, meaning that the body will get rid of more glucose. Based on that, what will happen if the glucose is leaving the body and accumulating in the urinary tract? I can take Amr to share some thoughts with me. Hi, Amr, how are you? Can you open the mic?
Hi, Doc. How are you?
Hi, I'm good. How are you?
I'm good, thanks.
So, for the gliflozin family, they act by enhancing the secretion of glucose from your body by preventing the reabsorption. So, in your opinion, what will happen as a side effect if your body is getting rid of more glucose?
Diuresis, for example, like increase urine volume.
Exactly, because the glucose will take water while leaving. So more diuresis, which is a higher chance of low blood pressure. Correct. What else will happen?
One of is like urinary tract infections, I think. And
exactly, because it will be a suitable medium for the bacteria and fungus to develop.
Yes. Volume depletion somehow, especially in like people, like elderly patients at risk.
Yes.
Yeah.
So the patients might go through diabetic ketoacidosis.
Yes.
Because the patient is losing more fluids, the patient already has high blood sugar, so this increases the risk of diabetic ketoacidosis. Okay?
Yes.
Thank you, Amr. Okay, so regarding this family, empagliflozin has shown a good cardiovascular benefit. So if you have a diabetic patient and the patient has cardiovascular disease and you are thinking of adding something to this patient if his blood glucose is not controlled with one medication, we will select empagliflozin because empagliflozin has a positive impact on cardiovascular outcome. However, canagliflozin has increased the risk of amputation in some patients. So if someone has a risk of amputation, he or she needs to avoid canagliflozin on that case. So this family is taken once daily, preferably with the breakfast, like right before breakfast or with breakfast, and it has a long half-life, so it will cover the whole day. Okay. Canagliflozin is contraindicated if the patient has a history of bladder cancer or has an active bladder cancer now, because it increases the chance of developing a bladder cancer, but we can generalize this contraindication to the whole family. avoid gliflozin in patient with active or history of bladder cancer. Then we have a new and effective family called GLP-1 agonist, glucagon-like peptide receptor agonist. Most of them are injection. One of them is oral, but it's not commonly used like the injection. So we all know about Saxenda injection, which is the liraglutide, and Victoza, which is liraglutide 2, used in losing weight. So this family acts by increasing incretin hormone. And when the incretin is high, the insulin secretion will be high. For this family, we have 3 main popular members. The first one is liraglutide, which is the most popular one. Then we have exenatide, and we have dulaglutide. The difference between these 3 is that exenatide is associated with meal. I will take it prior to meal. And it has 2 strengths. Exenatide has 2 strengths. One of them is a 5 microgram, and this is taken twice daily. Also, it has another high strength, which is 2 milligram, which is only once weekly, and they are all subcutaneous. This is regarding exenatide. The other one is dulaglutide, and we take it without, or it doesn't matter with or without food, and it's taken weekly. And the last one is liraglutide, which is taken on a daily basis, and also it doesn't matter with or without food. Okay, the semaglutide, the oral one, is not commonly used anyway. The glucagon-like peptide agonist decrease the HbA1c by up to 1.5%. It decreases the postprandial glucose, and like around the day 2, it decreases it. So if we say it decreases the postprandial glucose, we will be focusing more on exenatide, the low strength, which is 5 microgram, that's taken before meals. But for the one that is taken weekly, it's controlling like the glucose all around the day, not only the postprandial. Administration must coincide with meals. This is regarding exenatide 2, and liraglutide, the Saxenda, can be taken with cardio. It's not only safe in cardiovascular disease, it's preferable, as we said, like empagliflozin, because they have shown positive outcome in cardiovascular disease. The side effects associated with the GLP-1 agonist are pancreatitis, also weight gain, and this is a weight loss, sorry, and this is why liraglutide might be used for weight loss, one of the options for weight loss. Just it's expensive, but if the patient has coverage that accept to cover it, the doctor will go for liraglutide for weight loss, regardless of the diabetes. Even if the patient doesn't have diabetes, many doctors will give liraglutide. Also, it's associated with nausea and vomiting, and it might cause tachycardia. Glucagon-like peptide should be avoided in some issues. If the patient has a specific cancer of the thyroid gland, we don't have to go deeper in that. Not with all thyroid gland disorder. We will not say like if a patient has like kind of mild or moderate hyperthyroidism, it's not a contraindication for GLP-1 agonist. However, if the patient has a cancer or a history of cancer in thyroid, at that point, it's contraindicated. Yeah, semaglutide is oral, yes. It's available as oral and injection. The one to be taken with a meal is exenatide, and it has 2 strengths. One of them is very low strength, 5 microgram, and it's taken twice daily before meals. And the other one is high strength, 5 milligram, and it's taken once weekly. Okay, also glucagon-like peptide is avoided in atrial fibrillation. Okay. Medication that can prevent diabetes mellitus, like, why would someone take a medication to prevent diabetes? What is the meaning of that? Like, who has a chance of diabetes? And this is why we might need to prevent it in advance. A patient with a history of diabetes, like from both sides, from his father and mother, they have diabetes. The patient has a higher chance then of developing diabetes. So the doctor might decide at that point to give him something to prevent the development of diabetes. And the abbreviation for that is, yes, Ayman. MATO, M, metformin, A, acarbose, T, thiazolidinedione, O, orlistat. And to be honest with you, you will not find that the doctor is giving someone glitazone for the prevention of diabetes. The doctor might give metformin for a better control of glucose, might give orlistat to control weight and limit the chance of developing diabetes, but not glitazone, for example. Okay. Medication safe for heart disease, we can substitute the word safe by preferred. Medication that show positive impact on cardiovascular disease patient. It's empagliflozin, liraglutide, canagliflozin, and the canagliflozin is not that preferred because of the chances of amputation that we mentioned, and also because it's highly affected by the cytochrome B enzyme inducer. This is why EMPA and LIRA are the most common ones added to diabetic who has cardiovascular issue. This is a complicated thing that we don't need to look at even, ignore it. Okay. Now we were talking about what to give a diabetic patient, the treatment of diabetic patients. We were only talking about diabetes separately. Let's remember what we said earlier. I will take Jad K. Would you like to open the mic?
Yes, I'm Nuha. I didn't change the name.
You are whom, sorry?
I'm Nuha. I forget to change the name.
Noha Quebec?
Yeah, Nuha Quebec.
Noha Nafash. Hi, Noha. How are you?
Hi, I'm fine.
So, if we try to remember what we said about diabetes generally in a simple way, how to deal with a diabetic patient based on the HbA1c reading. Do you remember?
I think we have to look at the age also, and HbA1c, it must be under 6.5. We monitor every 3 months. Am I correct? Is that what you asked about?
Can you raise your voice and repeat again, please?
Okay. I didn't get your question, but as I understand, A1C must be under 6.5. We monitor every 3 months. And for diabetes patients after 40, age of 40, you have to look at the cholesterol and hypertension and other cardio problems.
Yeah. And my question was, if I already diagnosed a patient with diabetes, okay?
Yes.
What will I give him? Which medication? I will select the medication based.
Usually we start with metformin if they don't have any contraindication.
Yeah. So I will first look to the HB. I think you missed us. You were not with us from the beginning, correct?
Yeah, I'm not with you.
No, okay. Okay, so no worries. So we said that we will measure the HbA1c, and if it's less than 1.5% above target, it means that we still can do some life change that might help without taking medication, like exercise, amendment to diet. And in 3 months, we will have a look. If the patient is showing clear response, that's great. No need to give medication. And the patient has to keep on doing that, like kind of a change, exercise, control diet, and that's it. But if I measure the HbA1c and it was 1.5% or higher above target, at that point, I have to start the metformin, okay, right away. And I will assess the patient in 3 months. If the patient is showing enough response on metformin only, that's fine. If the patient is not showing enough response, I will add something to the patient based on the situation. Like I can add sulfonylureas, for example, but if the patient has kidney issue, I will give gliclazide rather than glypuride. Okay, if the patient is obese, I will think about giving something to decrease weight. So I might think of liraglutide. If the patient has a cardiovascular disease, I might prefer empagliflozin or liraglutide. So the decision of adding something to metformin will be based on what other conditions does the patient have, okay?
Okay.
If the patient, the third situation, if the patient has like clear metabolic decompensation, like diabetic ketoacidosis, for example, I need to give insulin at that case, in addition to the oral medication, because the oral medication will not solve the situation. I need to give insulin at that case until everything is getting back to normal, okay? And the reassessment is done every 3 months because the change in on HbA1c will appear after 3 months. So I will decide by making the test after 3 months and see what's happening, okay?
Okay, thank you.
Thank you. Okay, now it's not only about the anti-diabetic medication. It's about something else we need to use for the diabetic patient. Because the diabetic patient is at a high risk of developing other disease like atherosclerosis. The patient is at a high risk of developing chronic kidney dysfunction. So other medication has to be added for the diabetic medication. So the first one we have to think about is the statins, something like atorvastatin or rosuvastatin. When we add it, first, if the patient is diabetic and over 40 years, I need to add statin at that point. If the patient is diabetic and the age is over 40 years, I need to add statin. Or if the patient is less than 40 years, but he has a history of diabetes for more than 15 years. Like, for example, Mr. X is 37 years old and he has diabetes. I don't think like, okay, he is less than 40, so no need to add statin. No, if the history of diabetes with him is more than 15 years, like he started to have diabetes when he was 21, for example, so he has diabetes since 16 years now. He has diabetes for 16 years now. So I need to add the statin at that point as a kind of protection to the blood vessels, okay? Or even if the patient, regardless of the age, has like a macrovascular issue, like a patient has nephropathy, for example, which means that his blood vessels are now not performing very well. At that point, I will add the statin, even if the patient is less than 40 years, okay? The next family I need to add is ACE inhibitor or ARB, but ACE is more common, but I can still use ARB too, especially telmisartan, and I use it if the patient age is 55 years or more, not only more than, no, we need to put here something to mention, 55 years or more, and the patient has cardiovascular risk factor. Also, if the patient has any microvascular disease, retinopathy, nephropathy, I need to add the ACE inhibitor at that point, regardless of the age. If the patient has macrovascular disease, something like stroke, history of a stroke, for example, the patient has heart failure, at that point, I need to think about the ACE or ARB as a protection. When we decide to use the ACE inhibitor or the Noha Kepek, we have two persons now, Jade and Noha Kepek, the same person. Okay. What I was saying. Yeah. If I decide to use ACE inhibitor or ARB, I need to make sure that I'm using the maximum strength. You will find it so common for a diabetic patient to be, for example, on perindopril 8 milligram or telmisartan 80 milligrams, the high strength. So it's usually the high strength to be selected of the ACE inhibitor or the ARB when added to, when added to the medication, to the diabetic patient. Okay, the third thing I need to think about is aspirin. But aspirin is not used for primary prevention. Like if someone is diabetic and doesn't have any history of cardiovascular issue, no stroke, for example, no myocardial infarction, he doesn't have any history, so I don't take aspirin as a primary prevention. However, if the patient has a history of cardiovascular disease, like a patient developed a stroke before, developed blood clotting, at that point, I will consider aspirin as a secondary prevention. So aspirin is not used as a primary prevention. However, it can be used as a secondary prevention. Okay, statins, ACE, aspirin. Okay, regarding type 1, we don't have to think much about that. This is the insulin pump. And the kind of insulin we usually use is the short acting or the regular acting, just to be associated with meals. And this is how the insulin pump works. And the cannula and tube has to be changed every 2 to 3 days. It's not our business to think deeply about that, but all what we need to know is the type of insulin used in the insulin pump is either the short acting or the regular acting one. And this is how it is. The tube is going here until reaching the subcutaneous tissue to release the insulin. And it needs a lot of training for the patient to know how to use it. Okay, regarding the insulin types, this is a very old information that we might all know about. So if we look here to this one, we have the ultra rapid insulin, which is like insulin lispro or aspart or glulysin. And this insulin, the onset of action is like in 10 minutes, it gives effect, and its duration of action is up to 4 hours. And we know that we take it like just before meals, something like Novorapid, for example. The second one is regular insulin, like Hemolin R. And this insulin, the onset is somehow longer than the rapid acting, up to 45 minutes, between 30 to 60 minutes. And its duration of action is up to 7 hours. And both of these are considered bolus insulin. Bolus means that we give it before meals, okay? And it's clear. These two are clear solutions. Okay, the third type, and it's a common type, is the intermediate or the NPH, insulin isophane. And the distinguishing point about it is that it's cloudy, NPH, and it's considered a kind of basal insulin. Basal means that it's not associated with meals, but it's taken to control the blood sugar all around the day. NPH is mostly taken twice daily, okay? The other types are the long acting. We have like glargine, we have DITEMIR, and we have diglodic. And the difference is that DITEMIR is the shortest duration of action between them, this one. This is why it might be taken twice daily at certain conditions. Glargine half-life is longer, like up to 1 day, like 24 hours, like Lantus, the most common one. And we have also Tresiba injection, which is diglodic, and the half-life of this one is up to 42 hours. However, it's still taken once daily. So diglodic and glargine are taken once daily. DITEMIR is either taking once or twice daily. The decision is up to the physician and depending on the reading of blood sugar in the patient. Okay, so this one, the red one, the rapid acting, will be taken right away before meals because we said that it gives action in 10 minutes. This one will be taken like half an hour to 1 hour before the meal. This one is unrelated to meal, taken twice daily. This one are taken mostly once daily, preferably at bedtime. As we see here, this one has a peak, has a point where it reaches the maximum strength or the maximum concentration in blood. This one too has a peak, okay? This one, the long acting, we call it peakless, like because it gives a coverage for a long time, almost throughout the day, the whole day. So it doesn't give a specific peak. Rather, it gives like a long coverage during the day. This is something we don't need to care about that much, like the syringe, plunger, needle. Like this is not something we need to focus on. We need to know like the preferable sites of injection. Abdomen is a preferred one for many reasons. The first is the availability of subcutaneous tissue. The second is that it's the most easier for the patient to reach by himself. Also, the outer thigh is another preferred option for the patient. The patient also can use it as the subcutaneous tissue on the buttocks. However, abdomen is the most preferred one, then the outer thigh. And the back of the upper arm too. But the problem with the back of the other arm for people who are not, who are slim, sometimes they might get it intramuscularly rather than subcutaneously. If they are so slim, the subcutaneous tissue in that area will be so limited. This is why it might be injected by mistake in the muscle. This is why abdomen is highly preferred. Okay. Regarding insulin mixing, what we need to know is that long-acting insulin is not to be mixed with something else. Long-acting cannot be mixed. However, the rapid or regular acting can be mixed with NPH, like Novolin 770/30, like Mixtard. All of these are a mixture of intermediate acting insulin with rapid or regular acting, and is taken twice daily. Okay. Yeah, switching insulin. We cannot put this as a general rule, like switch from one insulin to another with 20% reduction in dose. I will share something with you to give you more details, which is, where are you? Yeah. I hope that I can share the screen. Do you see this table now? Do you see the table now? Okay, so this is the actual thing that we depend on. And so if we are converting a patient from the intermediate NPH to long-acting, something like Levemir, for example, we convert it unit by unit. Okay? So if the patient is receiving 50 units of NPH, he will be receiving 50 of DT-MER, okay? If we are converting the patient from NPH to Lantus, insulin glargine, we will be this is the important point, and this is what we need to focus on. Okay, so we said that for NPH, the patient might be taking it twice daily, which is more common, and in specific cases, the patient might be taking NPH once daily. If the patient is taking NPH once daily, we will convert it to the same amount for Lantus. Like the patient is receiving 50 units of NPH at night, and we need to change him to insulin glargine, we will give him 50 units of glargine at bedtime without any change. However, if the patient is taking NPH twice daily, like 25 units in the morning and 25 units in the evening, at that point, and I'm converting him to once daily insulin glargine, at that point, I need to reduce the daily dose by 20% and give once daily. So the total given from NPH is 50 units, correct? If I need to decrease it by 20%, it will be 10 units less. So the patient was receiving 25 units in the morning of NPH and 25 units NPH in the evening. I will be giving him 40 units only of insulin glargine in the evening. This is where I reduce it by 20%. You don't need to go further through the table because this is the most common conversion that is done in the hospital between NPH and glargine. Okay? And the change happens if the patient has been taking NPH twice daily and now is converting it to insulin glargine once daily. Okay, where I was here. Okay. Next, traveling with insulin. If someone is moving from Ottawa to where? To Fredericton, for example, from Ottawa in Ontario to Fredericton in New Brunswick, the trip is like 3 hours. Nothing need to be changed. As it's less than 5 hours, nothing need to be changed. The time difference is only 1 hour between Ottawa and Fredericton. A patient is traveling from Ottawa to Victoria in British Columbia. The time difference is 3 hours. Nothing need to be changed. It's still less than 5 hours. However, if a patient is traveling from Ottawa to Cairo, it's almost 6 hours difference. Time zoning is 6 hour difference. I need to look, it's more than 5 hours, so I need to think about the change now. So depending on if the flight is to the east or to the west. So from Ottawa to Cairo, I'm traveling to the east, meaning that the day is shorter. Like, let's say what happens here. If I have a trip at 12 p.m. today from Ottawa to Cairo, and the trip will take almost 12 hours. Anyway, when the time now in Cairo is, if it's 12 p.m., the time in Cairo is 6 p.m. Okay? If I travel at 12 p.m. from Ottawa, I will reach Cairo at 12 a.m. according to Ottawa time zone. It's 12 hours of flight. If I travel at 12 p.m., I will travel there at 12 a.m. at Ottawa timing zone. However, when I reach there in Cairo, the time will not be 12 a.m. It will be 6 a.m. there in Cairo, okay? Which means that almost 6 hours are missed from the day. The day will be shorter for me. At that point, I need to change the basal insulin by 25%. Like if I'm taking 100 units of Lantus, I will take 75 units of Lantus because the day is shorter, almost 6 hours are missed. So if I take the same amount of insulin, Lantus, glargine, it means that there is a higher chance of hypoglycemia. However, the contrast will happen if I'm coming from Cairo to Ottawa. If Mr. Y is traveling today at 12 p.m. from Cairo to Ottawa, he will leave at 12 p.m. from Cairo and he will reach Ottawa at 12 a.m. according to Cairo time zone. But what actually happens is that once he reaches Ottawa, the time will not be 12 a.m. The time will be 6 p.m., which means a longer day for this patient. At that point, I need to ask the patient to take extra meal and take one extra bolus insulin like Novorapid or whatever bolus insulin he is taking. Okay, this is regarding the slight change I need to consider. The other point is, if you are a diabetic patient with insulin, logically don't leave your insulin on the big bags that will go to the storage of the plane. Carry it on your bag or on the carry bag, your personal bag. Make sure that it's not exposed to sun. Make sure that it's not shaken. Insulin shouldn't be shaken, and it's better to keep it with ice box. However, we know that insulin can be kept outside the fridge for 28 days. And for Deglotic, we can, for the long-acting one, which is for up to 42 hours of action that we were talking about, I forgot it. So we have glargine, 24 hours. We have DTMR, 18 hours is the half-life. And we have the last one. What was the name of the last one, people? I forgot. DTMR, glargine. Hopefully someone wrote it. Deglotic, yes, sir. So Lantus can be kept outside the fridge for 28 days. But if you keep it outside the fridge, you have to get rid of it after 28 days. Okay, so it's still an option for a traveler to keep the insulin outside the fridge, but the patient has to make sure that it's only valid for 28 days now. Okay. We have two important phenomena that happens to the patients, and we need to understand. Dr. Habash is saying that if the patient traveled from Egypt to Canada, the day will be longer, so the patient will need to take extra meal, so we will increase the dose. Yeah, like the patient will need to take extra meal, and we need to give a bolus insulin at that point for the extra meal taken. On the other hand, if the patient is traveling from Cairo to Ottawa, from Ottawa to Cairo, the day will be shorter, so the patient has to decrease the amount of the basal insulin by up to 25%. If he is receiving 100 units of Lantus, he will be receiving only 75 units because the day for him is almost 18 hours on that day, not 24 hours. For insomnia as dealing with jet lag. Yes, Hamr. Okay. So we have Somogyi effect and we have dawn phenomenon. Okay. So what happened at dawn phenomenon? Generally speaking, in our body, when you wake up in the morning, your adrenaline, your insulin is high in the morning. Your cortisol, because you need power, you need to start activity. So it happens in all of us that the levels of hormones are higher in the morning. If we are talking about a diabetic patient, you will find that the cortisone level is high, the growth hormone is high, glucagon is high, and it's normal for the patient to have hyperglycemia in the morning in a diabetic patient, okay? If it happens, we will ask the patient to take the basal insulin right away before bed. Like the patient might be taking Lantus at 8 p.m., for example, but the patient to go to bed at 10. No, we will ask him to take it at 10, so the basal insulin can give more control on the morning glucose level. The other option is that if you wake up in the morning and you have hyperglycemia, take your fast-acting insulin in the morning. So this is like dawn phenomenon is not complicated. It's a kind of normal thing to happen. But the thing that might happen and need more effort is what we call the Somogy effect. Somogy effect is the patient during the night at around 3 or 4 a.m. will have hypoglycemia. His blood glucose will go low. So what will happen by your body as a normal reaction of the blood glucose will go low? The body will try to increase the glucose level in your body by increasing the amount of hormones that will contribute to increasing your blood glucose level. This will lead to a rebound hyperglycemia later in the morning, in the early morning. Okay, so what is the solution in that case? What happens is that a patient has hypoglycemia during the night and the body reacts by hyperglycemia to compensate this hypoglycemia. So I can solve it by preventing the hypoglycemia that happens during the night. And how I can prevent the hypoglycemia? By decreasing the basal dose. If he is taking 10 units of Lantus insulin glargine, I can try to decrease it by 10% to 9 units and see if this will solve the situation or not. The other option is that if the patient is not taking a meal at bedtime, I ask him to take a small snack, because the snack that he is taking at bedtime will help in preventing the hypoglycemia during the night and the rebound hyperglycemia that happens as the reaction by the body after. Let me clarify more. Samar Kassab, can you open the mic? Shayma, can you open the mic?
Yeah, doctor.
Yes, hi. So, is it initially clear regarding the dawn phenomenon and the Somogy effect?
Yeah, the Somogy is at 3 a.m. It has severe sweating. It means hypoglycemia.
Yeah.
But when he wakes up, he has hyperglycemia.
Okay. And regarding the dawn phenomenon?
I think both of them hyperglycemia.
Yeah, but the difference is that with the dawn phenomenon,
yeah,
the blood glucose during the night is almost normal, correct?
Okay.
Okay, so if I have a patient, a diabetic patient who developed hyperglycemia in the morning, I need to differentiate if it's Somogy effect or dawn phenomenon, correct? Let's say that he has a blood glucose of 11 in the morning. You are still with me, Shema? Or I'm sorry.
Yeah.
Okay. So let's say that I have 2 patients. And when I measure the blood glucose for them in the morning, it was 11, okay? How to differentiate if the first patient has dawn phenomenon and the second one has Somogy effect? I can do that by asking the patient to measure the blood glucose level during the night at 3 a.m., for example. The patient with Somogy effect will find that his blood sugar is low, may reach to 4 or 5 or whatever at 3 a.m. However, the other patient, which has a dawn phenomenon, will find that his blood glucose level at 3 a.m. is almost normal or even high, 6, 7, 8, something like that, which is normal for diabetic patient. So this is how I will differentiate between the Sumogai effect and the dawn phenomenon by measuring the blood glucose level around 3 a.m. for 3 to 4 days to make sure that it's a fact, not just like a kind of sudden thing that happens only one day. And if it's repetitive for 3 to 4 days, to find that at 3 a.m. the blood glucose level is low and then it's high in the morning, this is Sumogi effect. And if it's normal or high at 3 a.m. and still high in the morning, this is dawn phenomena. I need to make this differentiation because I need to decide what is the solution based on that. So if I decide that it's a Sumogi effect, so my goal is to prevent the hypoglycemia during the night by either giving like less units of the basal insulin. I try to decrease it by 10%, or by asking the patient to take a snack before bedtime. This is how we can prevent the hypoglycemia during the night. On the other hand, if it's dawn phenomenon, it means that it's a kind of normal thing. There is no hypoglycemia during the night. It's only hyperglycemia in the morning. So to control this hyperglycemia, I can either delay the basal insulin to be right away before bedtime, or ask the patient to take the fast-acting insulin in the morning with breakfast. So the dawn phenomenon is somehow simpler than the Sumogi effect. Okay, we need to differentiate between them, and we need to know how to deal with them. Okay, the other thing with diabetes is diabetic ketoacidosis. So generally speaking, our body depends on glucose as a main source of energy. What if a diabetic patient has a problem with insulin sensitivity, for example? His cells cannot benefit from the glucose, or the patient doesn't have insulin if he is type 1 diabetes. What will happen, or has a low level of insulin? The body will search for another source of energy, and the common source after glucose is the fat. So the fat will be degraded to fatty acids to produce energy. This degradation or this kind of oxidation will lead to the formation of acetyl-CoA, leading to formation of ketone bodies, acetoacetate and hydroxybutyrate. These ketone bodies will increase the hydrogen positive level in our body, leading to acidosis in the blood. This is why it's called ketoacidosis, and it's keto due to the formation of ketone bodies like acetoacetate and hydroxybutyrate. And what will happen when the H positive level, okay, Dr. Habash, when the H positive level is high in our body, it will lead to like, so we don't increase the insulin before bedtime and don't. Noha Kipik is saying, oh, Noha, can you open the mic, please? I got confused by writing.
Sorry, the question came late, but my question in down phenomenon, we don't increase the insulin before bedtime to avoid the hyperglycemia in the morning?
No, I want you to answer the question. I will not answer. What happens, Noha, in dawn phenomenon? What happens to your body?
How can I explain? In the morning, the patient has hyperglycemia.
Yes.
So to manage, we give him the insulin just before the bedtime. But why we don't increase the insulin a little bit to avoid the hyperglycemia? instead to give him fast rapid insulin in the morning. Doesn't work.
So we look to the givens, Noha. Okay. So what will happen is that I am a diabetic patient and I developed Dawn phenomenon in the morning. Okay.
Yes.
So I'm trying to look first for the simplest solution before going to a more complicated one. So I will see if I'm taking my basal insulin early, I will take it late. Okay.
Okay.
What if I take it late?
Okay.
I cannot go for this option. I have to find another option. The second simple option is that I take Novorapid, for example, 10 units before breakfast, correct?
Okay.
So I need to make sure that I'm taking my fast acting or rapid acting before breakfast, okay? Because this is what normally happens. And if the two options are not available, like the patient is taking Lantus at the last time before bedtime and taking his rapid acting insulin on time before breakfast, which is normal to happen, and the patient still have hyperglycemia, okay?
Okay.
So which is easier in that case, if this is what you are asking about? To increase the dose of basal insulin or to increase the dose of rapid acting insulin? Which is easier in your opinion?
Maybe the rapid?
Yes. Why? Because we already mentioned that during the night, the blood glucose level for Dawn phenomenon is under control, correct?
Yes. Yeah.
What will happen if you increase the basal insulin in a Dawn phenomenon? If the patient before going to bedtime, rather than taking 10 units of Lantus, he took 12 units. What will happen during the night?
Might have hypoglycemia.
And then we will develop the Dawn phenomenon to Sumugi effect, correct?
Okay.
So the easier is to change the dose of the rapid acting before breakfast, because I might need to make this a change. However, stay on the same units in lunch and dinner. So it's easier to make the change for the rapid acting rather than the long acting.
Okay.
Are you convinced?
Yeah. Okay, I understand. Thank you very much.
My pleasure. Okay, so in a diabetic ketoacidosis patient, the patient has high level of H, has ketone bodies, his breath will smells like fruit due to the ketone bodies, and he will develop dehydration and a lot of issue. So I need to deal with the diabetic ketoacidosis patient. What I need to do first? What is the first step in dealing with diabetic ketoacidosis? He is dehydrated. So before thinking about insulin or anything, dehydration is the worst risk now. I need to give him fluids first. Second is, because the patient potassium level might be depleted, because what happens is that the potassium level at the beginning will be higher. And when the potassium level at the beginning is higher, the body will try to get rid of potassium through the urine. So the patient might go through hypokalemia. In that case, I need to make sure that his potassium level is under control. If it's under control, I will give insulin. If it's very low, I will give potassium first, then I can give insulin. Okay, so the sequence is fluids, potassium, insulin, and at the end, I need to overcome the acidity by giving bicarbonate to equalize the pH in the patient's body. Okay. The risk of hypoglycemia for the blood glucose level to be less than 4. The risk factor are insulin, sulfonylureas, meglitinide. We talk about that. We need to monitor the blood glucose. And the symptoms of hypoglycemia, we have dizziness, sweating, heart racing, tremors, hunger, thirst. If the patient is in hypoglycemia, the patient might be conscious or unconscious. If the patient is conscious, still able to eat or drink, I will give him tablets, 15-gram glucose tablets, or 1 spoon of sugar, or 150 ml of juice or soft drink, or I can give him 1 spoon of honey. Then I will measure his blood sugar within 15 minutes. If the increase in blood sugar is less than 2 millimole, I need to give him again, to repeat it again with the same amount I give him. Okay? After 15 minutes, I will measure again. If the increase in blood sugar is still less than 2 millimole, I will repeat it again for the 3rd time. And after the 3rd time, if there is no response, I have to take him to the hospital. Let's have a scenario here with Armia. Armia. And last call for Armia. Unmute me. Do I have to unmute you? Okay. Ask to unmute. Hi, Armia. Hi, Armia. For the last time, hi, Armia. I'm trying to, and there is something that I don't understand, but I didn't have to unmute other friends. So I'm not sure what's happening. So that's fine, Armia. We can take Sarah. Sarah K.
Yes, hi, doctor.
Hi, Sarah. So I am a diabetic patient, okay? And I came to you at the pharmacy and you measured my blood glucose. I was complaining of like thirst, fatigue, heart racing, severe sweating, and I told you that I'm diabetic. So the first thing you did is that you measured my blood sugar and you find it 2.9. Okay. How will you deal with me?
So first, I'm gonna give either a glucose tablet or like a teaspoon of sugar.
Do you have a spoon of sugar at the pharmacy?
No, so like a cup of juice, or there would be the glucose tablets.
Yes.
And we'll measure after 15 minutes the blood sugar again. If it wasn't increased by at least 2 millimole, we'll repeat.
Give me numbers, please. This is why I told you 2.9, so it's easier for us to remember.
Okay, so if it wasn't increased until at least 4.9,
yes,
we'll have to repeat the same thing, like either give a glucose tablet or 150 ml of juice, and we'll measure again after 15 minutes.
Yes.
If it's still, if the blood glucose level was still not over 4.9, we'll have to refer or call emergency.
Yeah, call 911. I cannot ask the patient to drive because the patient will lose consciousness.
Yeah.
Okay. What if I'm the same person and you find that my friend is carrying me, running to the pharmacy saying, hey, my friend has lost his consciousness. And he told you that I'm diabetic, okay? And you measured my blood sugar and you find that it's 2.
Okay.
How will you deal with me in that scenario?
So if the patient is unconscious, we can give a glucagon injection. And I think we should wait maybe at least 5 minutes. If the patient didn't wake up, we call emergency.
If I didn't wake up in 5 minutes, you will call emergency, or you will give me glucagon again and call emergency?
No, we'd have to give glucagon again before calling, like do it together. Yeah.
Yes, exactly. And just for your information, there is like glucagon nasal spray now. It's for easier application. So if it's not a pharmacist or like a healthcare professional, the patient has the spray in his hand, and we teach the family member, like if he went through unconscious state, he can receive the glucagon like in the nose right away, and it acts very quickly, just for more convenience of the patients.
Yeah.
Okay.
Okay.
Thank you so much.
Okay.
We have a term called sick day management. Sick day management happens if a patient, diabetic patient, lost more fluids, like he developed diarrhea or he developed vomiting. So he is dehydrated. Okay. If a patient is dehydrated and he is diabetic, what will happen? His sugar will go up because it's not diluted. It's concentrated now due to the loss of fluid. So at that point, I need to make monitoring of glucose level more frequent than normal, every 2 to 4 hours. So Amr is asking how to detect or diagnose DKA. So first of all, it's not our business or as pharmacists to diagnose. This is first. However, the keto strips that is used through the urine can be given to the patient, and we ask the patient, if you start to feel fatigue, if you start to feel that the fruit smell of your breath is getting there, yes, Ham. So we give him the keto strips, and we ask him to make the urine test for the ketone bodies, and it will give him an indication of the amount of ketone or the percent of ketone bodies in his urine, and this might be an initial indication of ketoacidosis. At that point, the patient will be having a high fruit smell of breath. The patient has difficulty breathing due to the hyperacidity in his blood. You will find that a diabetic ketoacidosis patient is breathing like he needs to compensate the high level of acid in his blood by taking more oxygen. Okay. And also the patient will be extremely fatigued. And at that point, the solution is to go to the hospital, because I need to give him IV fluids. I need to measure the potassium level before either giving potassium or adding insulin, and the patient has to be closely monitored. So it's not a pharmacy business to get a blood test or whatever. He will be transferred right away to the emergency, but you can differentiate by initially using the keto strips, secondly, by seeing the patient who is severely fatigued and at the same time, very difficulty breathing, trying to take oxygen in a difficult way. These are like initial indications for the diabetic ketoacidosis. Okay, Amr? TY, okay, W, welcome. So, where we are, sick day management. So, diabetic patient losing fluids, so glucose will be concentrated in his blood, high glucose level. Okay, First, I need to monitor sugar level every 2 to 4 hours. For insulin, I don't have to change it as for now because the body has its defense mechanism already. Like the body will respond back by changing the hormonal release to acclimatize, to equalize the change in sugar level. This is at the beginning. Also, in addition to keeping the hydration to the patient, like 250 ml every hour to compensate the lost fluid, I need to make sure that the patient is not going in hypoglycemia too. So I will give him carbohydrates like 15 milligram every hour, and I can change the amount of fluid or carbohydrate given to the patient through the regular monitoring of sugar that I'm already doing. Like if I see that the patient is going in more hyperglycemia, I will limit the carbohydrate intake and increase the fluid intake. If I find that the patient is going to hypoglycemia, I will increase the carbohydrate intake and limit the fluid intake. So it's not a specific number to be given. It depends on the situation and the measurement reading that I get. Okay? In addition to that, I need to make sure that I am stopping certain medications in the sick day. These medications can be abbreviated by SAD-MANS. SAD-MANS. Before going through the details of SAD-MANS, can anyone tell me why in a sick day I'm going to stop specific medication? Like, what is the issue? Why I'm doing that? Renal function. Thank you, Amr. That's it exactly. So the medications we are going to talk about are highly affected by the renal function and by the volemic status of the blood. So when a patient is in a sick day, it means that taking these medications might lead to an increased level of this medication in the blood, leading to severe side effects. So I have to hold this medication for some time until the patient condition is restored to normal. These medications, the SAD-MANS, are sulfonylureas S, A, ACE inhibitor, D, diuretics. The patient is already dehydrated and lost fluid. It's illogic to give more diuretics. M, metformin, which we said is affected by the kidney function when we were talking about metformin. A again is ARB, like sartan family, telmisartan, irbesartan. N, NSAIDs, which affect the kidney. We talk about the prostaglandin rule on the afferent arteriole and this long story. So NSAIDs has to be held. And also S is the sodium glucose transporter inhibitor, the gliflozin. We need to stop this medication during a sick day, SAD-MANS. Okay, sulfonylurea, ACE inhibitor, metformin, angiotensin receptor blocker, non-steroidal anti-inflammatory, and SGLT2 inhibitor, gliflozin. Okay. Regarding the sick day, if a patient went through a sick day, when would I refer him to the doctor? When I would refer him to the emergency, depending on the reading. If the blood glucose is 14 millimole or more, it means that keeping him hydrated and blah, blah, these things are not enough. He needs more investigation and more monitoring, so I will transfer him to the doctor. If the patient is having vomiting or diarrhea for 6 hours or more, it means that the patient is going through a dehydration status, and I will not control it by taking fluids orally. The patient might need to take it IV. So I need to transfer him to the doctor. If the patient ketone reading is very high in the urine, I need to transfer him to the doctor. The ketones are so high, meaning that the patient is not benefiting from the carbohydrates I'm giving him, so a doctor needs to investigate. So when I'm going to transfer him to the emergency room, if the patient in a complete dehydration status, he needs to go to the emergency right away. If the patient developed diabetic ketoacidosis, at that point, we need to give him IV fluids. We need to get the potassium level measured in his blood. We need to give insulin IV. All these can be done at the emergency room. And if the patient has hypoglycemia and I keep giving him carbohydrates with no response, so the point of hypoglycemia is debatable. Like it might be to the doctor, it might be to the emergency. So we will decide that based on the given. You, as a great pharmacist, can decide if this is a severe hypoglycemia that cannot be controlled in a doctor, so we need to take him to the emergency, or it can be controlled by the clinic doctor. So you can decide that based on the given, depending on your professional judgment. Noha Quebec is asking, saying, when we say sick day, mean even normal flu or more complicated disease like UTI, CAP, blah, blah, blah. What do you think, Noha? Open the mic. Tell me about your professional judgment.
I'm thinking because even normal flu, we can count it as sick day. We have to manage or what we say.
Based on what you
monitor the, yes.
Yeah. Based on what you think, every diabetic patient who has flu or common cold has to stop his metformin and sulfonylurea and get it measured more.
That's my question. I don't think we have to, right?
Yes. Yeah, this is why I need you to share the thought with me so you don't forget it.
Okay.
So,
because, okay, CAP, UTI, disease like that, okay, but I'm thinking about allergic or common cold, or we don't have, right?
Yes, even with UTI, let's say, for example, that Mrs. Donna is a 49 years old and she has a UTI of E. coli or whatever, and the doctor decided to give her, what will the doctor give her, Noha? This is another question out of the topic, but let me see.
What we call it, TMP with sulfa.
Okay, this is one option. What if the patient is allergic to sulfa?
Nitrofurantoin.
Yeah, nitrofurantoin is a good option. She is 49 years old and she is post-menopause. For how long you will give her nitrofurantoin?
You make it 5 days?
When I say she is post-menopause, what is the benefit of this point in your opinion? When we mention that, no, when the patient is post-menopause, we deal with it as a complicated, not simple UTI, and in that case, we give the treatment for a longer duration, 10 to 14 days.
Okay.
We will discuss that if we're still alive until reaching the UTI.
Okay.
But just to mention here. Okay, so Mrs. Donna received a nitrofurantoin treatment for UTI for 10 days, okay?
Okay.
She has a UTI, but she didn't report anything of dehydration. She didn't report any vomiting or diarrhea or whatever. Do I have to deal with her as sick day?
No.
Okay. Keep about Mrs. Donna. Okay?
Okay.
Miss Donna, after starting nitrofurantoin, she developed diarrhea and she had to go to the washroom 6 times daily.
Now we can count it as a sick day. We have to manage.
Thank you, ma'am.
Okay, I got it. Thank you.
My pleasure. You know, you can think about anything and you can get the answer by yourself. Take it easy and simple and you will reach there.
Okay.
Okay.
Thank you.
My pleasure. For a pregnant woman who is diabetic, I might have somehow different targets of glucose level. If it's a fasting blood glucose, fasting glucose, I can get it like less than 5.3. This is totally acceptable for me. The postprandial, less than 7.8. This is totally acceptable for me. Like the 1 hour. If she takes something, she takes some carbohydrate and I measure the blood sugar in 1 hour, it can be less than 7.8. If it's 2 hours, less than 6.7. Don't confuse yourself with these numbers anyway. Just what we need to know that in pregnancy, numbers might change due to the hormonal change happening in the pregnant woman and due to the fact that there is another human being in her belly that is taking more calories, more carbohydrates, so the numbers will be different. But don't get yourself confused by these numbers. Okay. A pregnant woman. Before reading this slide, the most 2 important points we need to know is that for a pregnant woman who is diagnosed with diabetes, the choices of medication are insulin, metformin, or glyburide, nothing else. And if the patient has low kidney function, glyburide will not work at that point. So insulin and the metformin are a choice. If the creatinine clearance is less than 60, I need to decrease the dose of metformin. If the creatinine clearance is less than 30, metformin is contraindicated and it will be insulin. And what actually happens in life is insulin. Okay, this is the first point. The second point is that a pregnant woman who developed diabetes or who has diabetes already has to get eye exam done more frequently because pregnancy increases the chance of retinopathy. This is why the eye test has been done more frequently during pregnancy. Okay. To reduce the risk of preeclampsia, patients with pre-existing diabetes should start aspirin low dose at 12 to 16 weeks of gestation. Okay, like after starting from the 4th month, the pregnant woman need to start aspirin to decrease the chance of developing preeclampsia. Folic acid has to be begun at least 3 months prior to conception. Like if a pregnant woman is thinking about getting pregnant, she needs to start folic acid 3 months earlier. Okay, and it's taken as a 1 milligram daily, and we will continue it for the first 3 months. And then what actually happens if the patient keeps taking it during the whole duration of pregnancy. And as we said, the eye exam has to be done more frequently. Insulin, metformin, and the glyburide are the safest option, but what actually happens is that insulin is the one given to the patient. Pregnant woman with diabetes is considered somehow low immune person. So she needs to make sure that she is receiving her flu vaccine, her pneumonia vaccine, her pertussis vaccine, and recently her COVID vaccine. Is COVID vaccine safe during pregnancy and breastfeeding or not? Is COVID vaccine safe during pregnancy and breastfeeding or not? For the last time, last call, is COVID vaccine safe during pregnancy or breastfeeding or not, people? Okay, yes. Thank you. Oh, Ayman, I like your answer. I'm not sure. I really appreciate that, but it's safe. don't worry. Or they claim that it's safe. We don't know. Maybe after 5 years, they will find out that it was teratogenic, but they will discover that after 5 years. But as for now, it's safe. Okay, now I will not say that this is the diabetes, because the diabetes is an endless topic. And if we spend 6 years talking about diabetes, it will not be done. And there will be a lot of questions, a lot of thoughts about diabetes. We just covered the basic things, the things that we somehow need. However, there will be more details needed, and you will reach it by solving more questions, by looking to the topic on the CTC book, by asking me at any time if you have any question about it. So again, some topics like arrhythmia, like diabetes, has no end, and no one can control it as a whole. So we cover some points, some important points. We gave some ideas on how to deduce the consequences, the things, but still, you need to go deeper in that topic, reading CTC, looking to more questions, and asking me whatever, because I cannot cover everything, if you have any question about it. Okay, people? Okay. Okay, I think this will be the end of today. However, if you have any question, you can send me, and I will do my best to reply as soon as possible. Now we need to, I have to arrange this in the coming 2 days to finish the hypo and the hyperthyroidism, and they are not complicated, they are easy, and we can finish both in like 1 hour maximum. And also we will try to take the GI topics that we were supposed to take, like IBD, IBS, or whatever. I truly apologize for everyone if I'm somehow behind, but the kind of topics I was given needs more effort, and I have like an exhausting schedule. I work like 17, 16 hours per day. Only during this month, hopefully by the next month, I will not do that anymore. So I truly apologize for everyone if I'm behind somehow, but I will do my best to finish everything. And please, if you have any question at any point, send it to me, and I will do my best to respond to you. Thank you so much for today, and I will meet you soon, maybe in 2 to 3 days maximum. Okay, have a wonderful day, everyone, and I will see you soon. Thank you for everyone. Bye-bye.